In today's episode, I sit down with preventive neurologist Dr. Kellyann Niotis and lipidologist Dr. Thomas Dayspring to discuss what we can do to prevent dementia. Earlier this year, The Lancet published a report summarizing 14 established risk factors that, if addressed, could prevent almost 50% of all cases of dementia. This report provides a clear roadmap for what we should be doing, beginning from early life through midlife and into late life to reduce our chances of having cognitive impairment as we age. While we had originally planned to discuss all 14 of these risk factors in this episode, we ended up going quite deep on one of the 14 risk factors, elevated LDL cholesterol, which made sense with Dr. Dayspring joining us. We covered a lot of territory. Why is elevated LDL cholesterol a risk factor for dementia? How the brain produces its own cholesterol separate to cholesterol throughout the periphery, how genetics, specifically the two ApoE genes that we all have, one from mum and one from dad, affect cholesterol transport in the brain and subsequently risk of Alzheimer's dementia, how to know what ApoE genes you have, why ApoE4 carriers may need more DHA, an important long-chain omega-3 fatty acid, why eating cholesterol doesn't affect brain cholesterol levels, whether or not statins, which lower blood cholesterol, affect brain cholesterol and cognition, and a whole lot more. As is often the case here at The Proof, we went pretty deep. You guys know I love to get into the weeds. And in a day and age where faster is better, that's something I hope you appreciate and benefit from. That said, I do understand that going into the weeds can often be a little frustrating, and we need to be able to surface with key takeaways that inform the decisions we make about our health. So there are a few things I want to stress here from the outset to put your mind at ease. Firstly, you do not need to understand everything in this episode immediately. Try to stay curious and make notes along the way with key points and questions that you're left with. Dr. Kellyann Niotis is the only preventive neurologist in the country, and she'll be back on in future weeks to go through all 14 risk factors at a higher level. This is a complicated and rapidly evolving area of science, and this conversation that you're about to hear is really on the cutting edge of the field. Second, I've recorded short snippets of me summarizing important parts of the episode that I want you to walk away with. So we'll break away from the episode here and there for some direct conversation between me and you. Finally, I will do a solo episode summarizing the most important information from the Lancet report and my episodes with Dr. Niotis in the near future. I left this conversation with a huge amount of gratitude for the work that Dr. Niotis and Dr. Dayspring are doing. They're teaching us things that many neurologists and cardiologists, as well trained and brilliant as they are not yet aware of. Things that, if put into practice, could be the difference between having good cognitive health and quality of life in the later decades of our life and not. Hopefully all of that sounds good and you're excited for the episode. Let's get into it. Kellyann, Tom, thank you so much for joining us today. It's a real treat to have this time with two very esteemed doctors to help us explore neurodegenerative diseases and what we can do to prevent them. So really appreciate both of you being here with us.
Thanks so much, Simon.
Likewise.
Kellyann, given that this is your first time on the show, and Tom and I think we've done like 10 hours or so at this point. So people are pretty familiar with Tom and his background in lipidology, but perhaps we kind of start here by understanding the area of medicine that you practice. In your bio, it says that you're the first fellowship-trained preventive neurologist. What is a fellowship-trained preventive neurologist?
So that is my claim to fame. So my background is obviously in neurology, and I've been interested in the prevention of neurodegenerative diseases from the very beginning of my career. When I started looking into what can we do to prevent these things, I found very, very limited resources and very few people studying this topic. In fact, I only found one person, and he was at Weill Cornell by the name of Richard Isaacson. So I did everything I could to track this man down. It's like, I want to study with you. I want to do better. We got to do better for our patients. And we actually created a fellowship specifically for me at Weill Cornell. So I did that. And subsequently, there have been no other fellows to complete this fellowship. I remain a lonesome warrior in the field of preventive neurology. And that's mainly because, at least in the US, there really aren't insurance reimbursements for these types of services. So there's really little incentive for traditional neurologists to start providing these types of services to their patients.
And is that different to preventive cardiology or other fields of medicine? And is that downstream of a lack of evidence, say historically, that these diseases could be prevented?
I think it's multifactorial. When I first started, saying dementia and prevention in the same sentence was total taboo. I got looked at like I had 5 heads. Like, what are you talking about? You can't prevent dementia, and forget about Parkinson's disease. There's nothing you could do to prevent that. But, over time, as the evidence has exploded, and I know we'll talk about today on this call, it's become a little bit more mainstream, and people are actually understanding that there are things that you can do to reduce your chances of getting one of these diseases. But when it comes to things like preventive cardiology, Tom could probably speak more on this, but in the 1980s, they started this field of preventive cardiology, but it wasn't until 2010 that they actually started reimbursing for preventive cardiology services. So all those years went by and we weren't doing a whole lot in terms of providing prevention services to patients. I think the same path, unfortunately, will be true for neurology. It'll take a long time for the field to catch up and actually start doing something.
Right. So just to be clear, we're talking about the United States here, I presume. If you're in your, let's say, midlife 40s or 50s and you're screened, and we might get into what screening means in this context of dementia and whether it exists, but hypothetical scenario here, you're screened, you're considered high risk of developing dementia, you don't have it. You're saying right now you would have to use private funds to access treatments to help prevent that?
Absolutely. Most doctors wouldn't have any interest or incentive to really see someone who just has risk factors or family history of one of these diseases.
And so and I'm sort of just thinking on the fly here, having read through a lot of the risk factors, there's quite a bit of overlap with cardiology. So I presume a bunch of these people are at least being captured by preventive cardiology, which would have sort of indirectly an effect on dementia as well by managing those shared risk factors.
No, I personally, living in that world of trying, I'm not a cardiologist, but I guess I'm a preventive atherosclerotic doctor. And funny, our mindsets are alike, because I got into this in the 1980s, because for 15 years I was sick of treating acute myocardial infarctions and ramifications, chronic angina, blah, blah, blah. And I surely recognize that the only real thing is to learn how to prevent these diseases. And that's when I took a deep dive into lipidology and tried to understand the lipid aspect, because I sort of knew that's going to be key in preventing this disease. So we wound up there. Back then, cost wasn't that much of a problem because you could always code it as hyperlipidemia, hypertension. You weren't really writing preventing anything because you knew that wouldn't get covered. But there were easy diagnoses that you could get some reimbursement. But over many, many years, the process evolved, and I think we can now totally take out atherosclerosis if we understand it. But even, I met Kellyann, I don't know, it's probably 3 years ago where we became colleagues together. And we were two peas in the same pod, wanting me to prevent atherosclerosis, but her to preventing chronic brain disease. But they often go hand in hand in the same people. So we had a lot of teamwork going back and forth. And The last thing I'll say is because she tracked down Richard Isaacson and wound up in his little network. But, people ask me, Tom, you're always talking now about lipids in the brain. How in the world did you ever get into that? And I'll give Kellyann a lot of credit for reestablishing or stimulating me, but it goes back to I was working in the biomedical labs starting in 2012, and I became, very friendly with our friend Peter Attia at that time. And Peter was actually pretty tied into Richard Isaacson, Peter being wanting to prevent chronic brain disease too. So through Peter, I met Richard Isaacson. And Richard at that time was sort of in his lipid infancy and wanted to know a lot about lipidology, which was like the first neurologist I ever met who wanted to learn about lipids. So we became buddies and went back and forth. I learned from him. He learned a lot from me. And I didn't even know at the time he was training Kellyann there. And then it wasn't that long afterwards, we bumped in together. So we have a lot of commonality. So there is much, we're both of the preventive mindset. I can declare right now in 2024, I can pretty much take out atherosclerotic complications in almost anybody. We're way behind that with chronic brain disease. But the one commonality is the sooner in life we recognize who is going down that path to atherosclerosis or to chronic brain disease, that is the opportune time to jump in and start the therapeutics that we believe are probably going to work.
Yeah, that's absolutely right, Tom. I think when we think about preventive neurology and think about preventive cardiology, we have to think about these diseases as chronic diseases that start in people's 20s and 30s. So while it's never too late to start being proactive and to do something about potential pathology that could be developing in your brain, really we should be thinking about this in people's 20s and 30s.
Right. And I think, or at least from my perspective, and I'm in a bubble, I feel like there's growing appreciation that atherosclerosis starts early in life. I think there's less appreciation that a pathology like dementia, which when people hear the word dementia, I think usually they think of someone, in an old person's home who's 80, 90, and they think, okay, that developed in the last decade or so of that person's life. They don't associate that with lifestyle choices in their 20s. So there's a bit for us to unpack there. And I think we've also kind of made it clear why Dr. Dayspring is joining us today, because there is this overlap between cardiology and neurology, particularly with lipids. And there's a lot of confusion when it comes to lipoproteins in the brain and lipoproteins in the periphery. So between the three of us, I'm hoping we can clear up quite a bit of that confusion. And because there is so much, to kind of cover on this topic, and I wanted to be careful that we didn't bite off more than we could chew. Today, we're going to focus on preventing dementia and understanding a little bit more about what dementia is and those risk factors. And then we'll set aside time for future conversations to think about other neurodegenerative diseases and also treating dementia, which, as I understand it, is a little different to preventing dementia. So let's get clear on what we're talking about here and define some terms, Kellyann. When we use the word dementia, what are we speaking to and what are we not speaking to?
Yeah, so that's a really great question and something that confuses a lot of people. Dementia is really an umbrella term. So just to give you a little bit more about my background, yes, I'm a preventive neurologist. Here we go. I need a cognitive test, but I'm also a movement disorders trained neurologist. So movement disorders focuses on things like Lewy body dementia and Parkinson's disease. These diseases can accompany or be accompanied by dementia or cognitive decline. So dementia is really this umbrella term that encompasses a lot of processes, some of which are neurodegenerative processes like Alzheimer's disease, Parkinson's disease dementia, frontotemporal dementia, Lewy body dementia, but some that are not neurodegenerative processes, such as pseudodementia, which we can see in people with depression. Things like drinking a lot of alcohol can lead to dementia. Those aren't necessarily neurodegenerative diseases, but they do fall under this umbrella of dementia.
And how do these different forms of dementia kind of manifest, or how could we differentiate between them in terms of, let's begin with clinical presentation?
Yeah, so this is a really active area of research. The first and foremost, we when we think about dementia, we have to think about what's the person's age, what profile of person are we looking at? Most cases of dementia are Alzheimer's disease dementia. There's also vascular dementia. There's also Lewy body dementia that are really common. We have lots of different tools in our toolbox to differentiate between different forms of dementia. When we first meet someone as a clinical neurologist, we want to make sure that we rule out all types of reversible causes of dementia. So things like B12, vitamin B12 deficiency can lead to dementia, screening them for depression, things I mentioned before. Make sure there are no low-hanging fruit. Make sure we rule out all possible etiologies that could potentially be reversed. Then we start going down the more neurodegenerative pathway. And the signs and symptoms that people present with can really differ between the various forms of dementia. A common thing that we see in Alzheimer's disease is speech changes or language changes, difficulty finding the right word, difficulty stringing together fluent sentences or following conversations, and of course, short-term memory loss is a big one that most people or family members will notice in their loved ones. For other forms of dementia, I know we're going to focus primarily on Alzheimer's disease and vascular type dementia, which there's a lot of overlap there. But in some other forms of dementia, you can actually see other cognitive changes that could be more subtle. For example, in Lewy body dementia, you can have visual spatial problems. So patients can have a hard time following plots of movies. When they're walking, they can take a lot of missteps or fall off of curbs. And that's just because they have really poor visual spatial awareness. It's also seen in things like Parkinson's disease dementia. So once you have these clinical symptoms, then you want to do more exploratory tests. And what is so cool and emerging in this field is that previously, we used to have to rely on things like lumbar punctures or spinal taps to get more definitive diagnoses, or imaging tests that required a lot of radiation. So things like amyloid PET scans or tau PET scans or FDG PET scans, looking at specific toxic proteins that can accumulate in the brain or changes in the brain's metabolic pattern. Now we have cool ways of identifying proteins in the blood. So in the last 3 to 5 years, blood-based biomarkers became available in the United States, and really they pioneered in Europe. So things like amyloid beta 42/40 can be tested in the blood and can suggest Alzheimer's disease or Lewy body dementia. We can test for things like p-tau 217, which is really more specific to Alzheimer's disease. And these biomarkers can become positive decades before the onset of symptoms, which gives us really a prime opportunity to identify who's at risk and to do something about it. I get a lot of sometimes negative feedback about, well, if you identify these people, you're causing really unnecessary or excessive worry in people, and there's really nothing that they can do about it. So why identify these individuals? Well, I mean, to that, I find that this knowledge is really empowering to people to understand that there could potentially be something going on and that it hasn't manifested yet. That's a prime candidate for prevention. We're going to do everything we can to get this person off the path.
Right. So it may not, and you can correct me if I'm wrong, it may not change the interventions, but it might give someone more motivation to look at. We're going to discuss a recent report on 14 of these risk factors. It might give people more motivation to get on top of those risk factors. Or if you notice that you have this heightened risk because of this blood biomarker test, would it actually mean that you might explore, other kind of pharmaceutical interventions as well?
I think it means both. I mean, we're going to talk today and stay pretty broad in terms of what people can do to prevent their risk. But really, there is a lot of personalization or individualization in this approach. before my current role, I was at Weill Cornell and did a lot of research on this topic of dementia prevention. And what we found was that if you start individuals on multimodal interventions, which include personalized diet, personalized exercise, personalized pharmacological therapy based on what their risk factors are and based on what we find in their blood biomarkers, that you actually move the needle much more than if you don't use that strategy. So I'm all about personalizing interventions. And I do actually think, while this is still debated and more will come on this topic, using biomarkers can be a really valuable way to kind of individualize our therapy and help track and monitor people's progression over time. Just like cholesterol. It's like a cholesterol test for the brain.
Can you give us an example, perhaps, of how a specific result with one of those tests may change the way that you treat a patient?
Yeah, absolutely. So there's a lot of buzz right now on these new GLP-1 drugs and using them for things like weight loss. Well, it turns out that they probably have beneficial effects in terms of what they do to the brain that are separate from the changes that they make to people's body composition. So we understand obesity is a modifiable risk factor for dementia. Of course, modifying that with a drug could potentially be beneficial, but what we're seeing is that these GLP-1 agonists actually improve tau pathology. So in the right person, they may be a good candidate for one of these drugs, depending on what we find on their biomarkers.
Coming back to these different types of dementia for a moment here, you mentioned some of the early signs of Alzheimer's, being speech or language changes, difficulty finding words, short-term memory loss. I think a lot of folks worry about kind of forgetting things as they get older. And I'm sure this is a question you get all the time. What is normal forgetfulness? And just, you're so busy, you forget something, or you forget a word that you had been using frequently, but then you find it, versus actually early signs of dementia that someone should be aware of and perhaps more concerned by?
This is a very common question, and it's really difficult to answer because there is a lot of overlap between normal cognitive aging and a neuropathic process. So normal cognitive aging, word is on the tip of your tongue. That is really common. You have word blocking when you really can't think of that word. Those things happen to everybody. As you alluded to, attention is a big problem. So I like to tell people there are stages that your brain needs to go through to form a memory. One of those is you have to pay attention so that you could actually learn the material. If you don't pay attention, you will never remember that information later on. 9 times out of 10, when someone comes to me and tells me that they're having memory complaints, they don't remember a conversation they had, they're losing their keys, it's because they're so distracted by all the other things in their life that they're not really focused on what's right in front of them. Or there are other external factors, like they're stressed out about something in their life, they're not sleeping well. All those things can have short-term impacts on memory. So important to rule all of those things out before you start thinking about, could me not remembering the right word be a sign of something more serious? In people who have certain high risk genetic variants, which we'll talk more about with Tom, like ApoE4, or in people who have a profound family history of dementia, I would just take all those complaints a little bit more seriously.
Remind me when we get to early learning as one of the risk factors that we come back to this idea of attention and focus, because I have to wonder if the increased use of mobile phones and apps and the distraction that kind of poses for the youth could be setting people up for kind of less cognitive reserve and perhaps declining cognitive function as people age. But let's put a pin in that and come back. While we're on this, on the topic of dementia and defining things, you mentioned that Alzheimer's dementia, I think you said that was the most common form of dementia. Just how common is Alzheimer's dementia and some of these other kind of more prevalent forms of dementia, and how likely are we to experience one of these?
Yeah, so what's really difficult about saying how much of dementia is from Alzheimer's disease or how much is from Lewy body is that at the end of the day, clinicians are really bad at diagnosing these diseases in real life, and often we have a formal diagnosis after death. So it's difficult, but we'll give the umbrella term. Neurodegenerative disease related dementia is about 55 million people across the world. And what's most startling about that is that there are 50 million people who are living in this preclinical stage of disease, meaning they harbor insidious markers of Alzheimer's related brain changes, but they don't have any obvious cognitive complaints, or their cognitive complaints are very subjective and wouldn't flag as abnormal on any cognitive test. That's massive. That's a massive amount of people that are in the coming years going to potentially be in this bucket of people with dementia.
Is that mild cognitive impairment, or is that term used to describe something else? And should we be thinking about this similar to how we think about pre-diabetes and type 2 diabetes?
Yeah, so mild cognitive impairment is not the same as preclinical disease. And I think this is actually really analogous to atherosclerotic disease, because you have this really prolonged silent period where something is accumulating, but it isn't manifesting. That's really the preclinical stage. Sometimes you'll have these subtle cognitive changes, but if you gave someone a cognitive test, they would not score in an abnormal range. Then you advance to this MCI stage, which is mild cognitive impairment. You do have abnormal cognitive function on objective tests, and you probably do have noticeable cognitive changes, noticeable by you or a loved one. And then, of course, you advance to the dementia stage, which is when you lose certain independent functions, activities of daily living become more difficult, and you start depending on someone else to hygiene and eating and dressing and so forth.
So about, I think you said 50 million people globally have a neurodegenerative disease, or 55 million.
55 million have dementia.
And then 50 million are in this kind of preclinical stage.
Yeah.
And you mentioned atherosclerosis, which is a pathology that we've walked through on this show quite a bit. How would you describe the pathology here in the case of dementia? And I appreciate it's probably different for these different forms of dementia, but as you move from kind of good cognitive health to preclinical to then having a diagnosis, what's actually happening in the brain tissue? What do we see?
Yeah, so there's a lot of different things that are happening, but we can base this on something called the ATN staging, which is amyloid, tau, and neurodegeneration. So this is for Alzheimer's disease. So what you see first is the accumulation of a protein called amyloid beta in the brain, also in the blood. After, this can happen for years and years. Potentially, it may never lead to tau. As you've heard, amyloid is insufficient to cause neurodegenerative diseases. Some people, a third of people, are walking around with amyloid in their brain, and they supposedly never will go on to develop a neurodegenerative disease. Tau is the next toxic protein that we see. So phosphorylated tau specifically, and it can be phosphorylated at different locations of this tau protein, which is probably above the topic or above what we should be discussing today. Tau accumulates in something called tau tangles in the brain. And then subsequently, these toxic proteins can trigger a lot of neuroinflammation, which leads to neurodegeneration. There are vascular issues that come along with these proteins that can develop that we see. The vascular issues can present similarly to vascular dementia, microangiopathic changes that happen. Amyloid can accumulate in the brain parenchyma itself and also in the blood vessels of the brain. But ultimately, this is the stages of what we see as the disease progresses.
And to be clear, that's Alzheimer's dementia.
That's Alzheimer's dementia.
Whereas something like vascular dementia is the pathology closer to what we see with, atherosclerosis throughout the body?
Yeah, so vascular dementia is, or used to be called multi-infarct dementia. So it's this entity that there's stepwise progression of cognitive changes, usually triggered by an infarct in the brain or a stroke in the brain that leads to cognitive decline. It can have symptoms that range from similar symptoms to Alzheimer's, which is short-term memory loss, but you can also have a lot of movement problems with it. Parkinsonism is common with vascular dementia.
So is it generally thought that if you address cardiovascular risk factors, you're addressing the same risk factors for vascular dementia?
Yes.
Okay.
Cardiovascular risk factors are key importance when we think about vascular dementia prevention.
Okay, so then we come back to Alzheimer's dementia, and it's this different pathology. What do we understand about the causes of that? What's causing amyloid plaque build up in the first place? Why in some people does it progress on to tau and then neurodegeneration, but not others? How much of this is that person's genetic makeup, what they got from mommy and daddy versus the environment?
Yeah. I mean, if I had the answer to that, I would win a prize. So we don't know. That's what the field is after. And anyone who says that we do know, we don't know. But there are lots of different hypotheses. So, of course, initially, we were all taught in medical school that amyloid is the sole driver for Alzheimer's disease. Well, with the advent of these anti-amyloid drugs, which are beneficial to some degree in some people, we understand that they don't eliminate the disease. And it has led us to understand that Alzheimer's or amyloid is not the sole pathogenic process that's happening in Alzheimer's disease. There's likely factors upstream that are driving amyloid and tau accumulation. And those factors can be things like, I'm giving you my thoughts and what's based on the evidence that we have, things like excessive inflammation and neuroinflammation, things like cardiovascular disease risk factors and vascular changes. Metabolic health is a big driver. Hormonal health in women can be a massive driver. So lots of different avenues can cause these proteins to accumulate. And the whole idea of preventive neurology is let's start addressing these risk factors that drive amyloid and tau pathology earlier in life so that we can prevent them from accumulating.
What's the relation between, I imagine a lot of people are listening and they're thinking, maybe they heard or they've gone and done a genetic test and they have a copy of ApoE4 or 2 copies. How does that affect that pathology, the process that you were talking about earlier, going from amyloid to tau to neurodegeneration?
We should double click on this. And this is kind of where Tom has changed my whole world on understanding this. It's mind-blowing to realize that ApoE is a lipoprotein.
It's an apoprotein. First it's an apoprotein when the liver makes it. And then apoproteins tend to bind quickly to lipids. Once it binds to a few molecules of a given lipid, usually cholesterol, then it's called an apolipoprotein. And once it accumulates with a whole mass of lipid molecules, then you have a lipoprotein. So there's sort of 3 stages. A lipoprotein is a collection of lipids that are surrounded by water-soluble proteins that provide structure, stability, and in ApoE's case, functionality to a given lipoprotein. So just to be clear on our terminology, an apoprotein is just a peptide attached to nothing.
And so, Tom, based on your genes, you make different proteins? Like I understand that some people have ApoE2 or ApoE3 or ApoE4 in a different combination. What does that look like?
Well, of course, genes control the formation of every protein in the body, but there's some proteins we're a lot more knowledgeable about and seem to be more linked to the diseases that are afflicting most of us or so. So one protein is, of course, Apoprotein E. And like all, we inherit genes from mom and dad. We get one allele, a copy of a gene from mom, one allele copy from dad, and then they get together in a given person. So your genetic makeup that's going to produce a protein is got two alleles afflicting it. Now, ApoE is a protein that comes in, for today's discussion, we'll say three forms, called isoforms. So are they different? Of course they're different, or we'd be saying they're all the same thing. And they're given the names E2, E3, and E4. Believe it or not, it's only one amino acid difference in each of those peptides that changes what we call it, but it also changes. You wouldn't think one amino acid would have much to do with anything, but with ApoE, it changes everything as far as what ApoE might be doing in a good fashion or a bad fashion. So because we can get an ApoE2, an ApoE3, or an ApoE4 from mom or dad, but when we put them both together, our genotypes are simply going to be E2, E2, E3, E3, E4, E4, or E2, E3, E2, E4, E4, E3, E4, E2. So there's a lot of genotypes. And depending on your genotype, that person will be producing a distinct type of apolipoprotein E. And when that ApoE binds to lipids, it's going to influence what can possibly happen to the lipoprotein that this ApoE is attached to. So, and then we'll get into this ultimately, but we're talking about two pools now. We're talking about the periphery, where God and you and I have discussed this for lots of hours, Simon, the type of proteins, the lipoproteins that float around our bloodstream. And of course, most of them carry ApoE, with the exception of LDLs. It's like the only lipoprotein that doesn't carry much ApoE. But then we are going to also be talking about the type of lipoproteins that traffic lipids in the brain. And one early little point to drive home is whatever the lipoproteins you have in the brain, or whatever they're doing in the brain, have zero relationship to the type of lipoproteins that are floating around your plasma. Now, there is ApoE on many of the lipoproteins in your plasma. ApoE does not cross the blood-brain barrier and become part of a lipoprotein in the brain. We will talk about that the brain can produce ApoE for sure, and it does things up in the brain, but it does different things in the plasma and how it modulates what might happen to a lipoprotein trafficking in ApoE. And a lipoprotein in the periphery that might be carrying E2 or E2 is going to cause those lipoproteins to behave very differently than if those lipoproteins were carrying an E4 allele or an E4, E3. The so-called common type, the wild type of ApoE is ApoE3E3. That's what most of us have. So we tend to compare, hey, if ApoE3E3 is the wild type, what happens to people carrying an E4 allele, or what happens to people carrying an E2 allele? And then we start to see the differences to it. And as always, the homozygous types, the E2E2, the E4E4, will even behave a little different than the heterozygous type, say an E4E3 or an E4E2. So it does get complicated. Now, we can easily measure your ApoE genotype and see what it is. Now, me dealing with peripheral atherosclerosis, I can correlate certain ApoE genotypes with your risk down the road for lipid disorders or even the development of atherosclerosis. I can even tie it into other things, such as the absorption of cholesterol in your gut in some people. But once we start talking about the ApoE genotype in the brain, and we'll let Kellyann do that, but a lot of that comes down because you do have brain lipoproteins, and the type of ApoE they have in wrapping their brain lipoproteins, just as I told you, ApoE can affect what various peripheral plasma floating apoproteins might do in the brain. your ApoE type, the specific protein you have on your brain lipoproteins has a lot to do with, are those proteins going to do the proper things, or are they going to be really dysfunctional type of lipoproteins? So that's a sort of a long mouthful of what ApoE is. It's a very important critical protein that infects the lipolysis, the catabolism, the internalization of lipoproteins in the periphery. And it actually does the same thing in the brain, except again, what is going on in the plasma has nothing to do with what's going on in the brain. So we do have to master lipoproteinology in the periphery. I hope we've done that in our many hours of podcast. But more in today's podcast, or if we have a subsequent one on it, we're going to have to talk a lot about the type of lipoproteins that are present in the brain.
Okay, breaking away from the episode, it's just you and me for a brief moment. As mentioned, there are three major types of ApoE genes: ApoE2, ApoE3, and ApoE4. Each of us have two copies of these, one from mum and one from dad. So there's 6 possible combinations that you could have: E2E2, E2E3, E3E3, E3E4, E2E4, or E4E4. E3E3 is the most common gene combination in Caucasian populations and is neutral in terms of risk of neurodegenerative diseases. About 70 to 80% of the population are E3E3. E4, on the other hand, is present in 14% of Caucasians and is the strongest genetic risk factor for Alzheimer's dementia. Less than 5% of the population have 2 copies of E4. This is the most unfavorable ApoE genetic combination when it comes to Alzheimer's risk. Having 1 or 2 copies of E4 also significantly increases risk of Lewy body dementia. By contrast, only 8% of Caucasians have 1 or more copies of E2, which is considered a longevity gene and decreases risk of Alzheimer's dementia, but can increase risk of cardiovascular disease and macular degeneration. These ApoE genes are responsible for the production of proteins in the brain that help transport cholesterol between cells, from astrocytes to neurons. While it's by no means fully understood, it's hypothesized that people who have 1 or 2 copies of ApoE4 have higher risk of Alzheimer's dementia because the ApoE4 protein is not very good at cholesterol transport, resulting in too much cholesterol building up in neurons, which ultimately can be toxic to neurons and cause cell death. If you think knowing your ApoE genotype would be something that empowers you rather than causing unnecessary anxiety, something that you'll have to decide for yourself, you can get it tested with a company like EmpowerDX, a company that I have no affiliation with. I used EmpowerDX to test mine, and my results were E2E3. I carry 1 copy of ApoE2 and 1 copy of ApoE3. So thankfully, no copies of E4 and 1 copy of E2, which is protective against Alzheimer's. But now the risk for me here is that I rest on my laurels and just assume I won't get dementia. That's not how it works. Plenty of people without copies of ApoE4 still develop dementia. It doesn't mean that I'm invincible and don't need to live a healthy lifestyle. It just means that I'm at lower risk compared to the average person. Okay, let's jump back into the conversation to learn more about Apoprotein E. A quick ad break to introduce you to one of our very important partners, 38 Terra, who helps make these videos available to you at no cost. 38 Terra's DMN prebiotic, which I'm holding up on screen for those watching on YouTube, is a science-based daily multivitamin for your gut microbes. It's what I take each morning before having my coffee. Taking DMN once per day ensures your gut microbes are well fed, and in turn, they will reward you by producing beneficial compounds like short-chain fatty acids. Get 10% off your DMN at 38terra.com using the code THEPROOF. That's 38terra.com and use the coupon code THEPROOF for 10% off. So, Tom, our previous discussions have made it very clear that ApoB is a protein that the liver produces such that we can transport lipids, so triglycerides and cholesterol, through plasma. Otherwise, these lipids, they wouldn't be able to dissolve into plasma. So by kind of combining them all up into this beach ball with this protein around the outside and stuffing the triglycerides and cholesterol into the middle, it can then dissolve and freely flow through plasma, and we can get triglycerides out to tissues to use to produce energy. Is the brain, which I appreciate now is a distinct kind of lipoprotein system from the periphery, is the brain producing, are there cells in the brain that are producing the ApoE protein for a similar reason to why we produce ApoB, to traffic triglycerides and cholesterol in the brain from A to B?
Now, quickly, in the periphery, ApoB is a gigantic apoprotein. It is the largest apoprotein that a human body can produce. Its molecular weight is 550 kilodaltons. ApoE, by the way, has a molecular weight of like 22 kilodaltons. So ApoE is so tiny compared to ApoB. Now, ApoB has to be gigantic because it's enwrapping very large lipoproteins in our periphery that are, as you alluded to, the biggest ones are carrying triglycerides, energy to the muscles and fat cells. So ApoB has to be quite big. ApoE jumps on the ApoB some of the ApoB particles in the periphery, all but LDLs, because ApoB serves as a protein that is a ligand for receptors that can clear various proteins. So that's one of the main functions of ApoE, both in the periphery and in the brain. It has an affinity for certain receptors that cells can express that by binding to ApoE will internalize it. In the periphery, ApoE is the main clearance mechanism of your very low density lipoproteins, the triglyceride carrying VLDLs, and the intestinal carried chylomicrons. They get cleared at the liver because the liver has a specific receptor called the LDL receptor related protein, LRP, which binds to ApoE. Interestingly, I told you it was such a small peptide. Chylos and VLDLs, being gigantic, carry multiple copies of ApoE. So it's easy for ApoE, for an LRP in the liver, to recognize some ApoE on one of those big dump trucks attached to it and pull them into the liver. So ApoE, that's one of the functions ApoE performs in the brain too. We're going to talk about neurons needing cholesterol. So neurons are going to have to somehow attach to brain lipoproteins that are carrying cholesterol and internalize them into the neuron. Well, the neuron expresses LDL receptor-related protein, LRP. The neurons can express the LDL receptor, which also has an affinity for ApoE. So that's how neurons, if the brain lipoproteins contain ApoE, and I'll let the cat out of the bag, that's what they contain as their structural apoprotein. That's one. ApoE binds to the same receptors a neuron will express that the liver cells will express to clear lipoproteins from the plasma. So there's that similarity there too. The difference is the peripheral lipoproteins, the ApoB particles, Simon, the cholesterol in them is being brought back to the liver. And the liver has the LRP and the LDL receptor to grab these ApoB particles and internalize them. Well, the brain is not capable of producing apolipoprotein B. Brain doesn't need it. It's a gigantic protein. No lipoprotein in the brain has the diameter, the buoyancy of a VLDL or an LDL. What are the tiniest lipoproteins in the periphery? There are high-density lipoproteins. And remember where the name comes from. In a centrifuge, the HDLs sink to the bottom of the tube. The VLDLs float on top, and the LDLs are in the middle of that centrifuge tube. Because the VLDLs have no density. They're quite buoyant. They float. LDLs have a little bit of density, but they carry a lot of lipids, so they float. It's the amount of lipids that ascribes buoyancy or density characteristics to a lipoprotein. So in the periphery, it's your HDLs. and they sink because they carry no lipids compared to the LDLs and the VLDLs. Well, now we've forever used the term high density lipoprotein. So anytime you utter that phrase HDL, everybody thinks you're talking about an HDL that's floating around our periphery, doing whatever HDLs do in the periphery. It turns out the brains have lipoproteins. And we characterize brain lipoproteins. We can characterize them by their buoyancy or density. Except every lipoprotein in the brain, if we put it in a centrifuge tube, it would sink right to the bottom because it has the density of a peripheral high-density lipoprotein. So we call them, yes, the brain has HDLs, but they're somewhat different than the HDLs that are floating around your plasma, except they have the same lack of buoyancy or they have the same density. And there's a density range which within these particles fall into. So we're going to talk a lot about brain HDLs, and it's going to get complicated. Don't think that the HDLs floating in your plasma can cross the blood-brain barrier and enter the brain and perform whatever functions HDLs form. The brain will make its own HDL density lipoproteins, but brain HDL particles cannot leave the brain and enter plasma, and plasma HDL particles cannot cross the blood-brain barrier and enter the brain. Where this is going to get a little sticky, and I'll stop taking all the time here, guess what? I told you the smallest apoprotein in the body is ApoA1, which is the structural protein on an HDL. Now, HDLs are small. How many ApoA1s does it take to coat a typical HDL particle? 2, 3, 4, or 5. So that's, again, even with a real tiny lipoprotein in the periphery, it still needs a lot of ApoA1 on it to give that particle structure and stability in plasma. So the HDLs in the brain also are going to have multiple copies of ApoE on it. But here's the thing. ApoA1 is such a low molecular weight protein. If we have free ApoA1 floating in our plasma, and we do, it's transient, but it's there. HDLs floating in our plasma, the ApoA1 on it is transferable. It can jump off and jump on other things. But as it jumps off, for a while, it's free before it binds to a VLDL or a chylomicron, which is what it typically jumps from. An HDL as a carrier of ApoA1 in the periphery. So ApoA1 being a 22 kilodalton eensy-weensy apoprotein can cross the blood-brain barrier. So what happens when ApoA1, free ApoA1, the entire HDL particle cannot cross the blood-brain barrier? That's way too gigantic. But its surface ApoA1, if it breaks off, can. And what does ApoA1 do when it crosses the blood-brain barrier? Just a little bit of more brain tissue going on. You would say, oh, it jumps into the arteries in the brain. No, it's free ApoA1 floats around all the arteries in our body, including brain arteries. See, when the brain makes a lipoprotein, it doesn't float in the arteries and the capillaries going throughout our brain. Brain lipoproteins traverse through, basically, it's an interstitial type of tissue. It's called the matrosome by some people. So if one cell in the brain makes a lipoprotein and excretes it, it travels through this matrosome until it bumps into another cell that can internalize it. And that ultimate final path is going to be the neurons that are looking to internalize these lipoproteins. I want Kelly to, as soon as I shut up, if I ever do, just give you the types of cells that are in the brain. But the lipoprotein producing cell in the brain are called astrocytes. So astrocytes make the lipoproteins, they make the ApoE that enwraps them, and they shoot these particles out and they sort of swim through the matrosome. They're not swimming through brain plasma. The brain lipoproteins do not get into brain arteries, capillaries, or plasma. And they traverse through the matrosome and run into neurons that can internalize them or delipidate them. So when an ApoA1 crosses the blood-brain barrier, you know what it does? It looks for the nearest brain HDL particle, and it binds to it because ApoA1 hasn't. It's a small apoprotein. It's looking for a small apoprotein, small lipoprotein to bind to. So our brain HDLs now, the phenotype is going to be, it could be an ApoE only HDL, or it could be a combination ApoE plus ApoA1 HDL. There may be future therapeutics related to this because, as Kellyanne's going to tell us, you don't want to have ApoE4 on your brain HDLs. Just like ApoE4 distorts what the type of lipoproteins carrying it does in the periphery, it's going to affect the functionality of a brain apoprotein. So the ApoE4 is probably going to turn a brain lipoprotein into a somewhat perhaps dysfunctional HDL. But the hope would be if ApoA1 can jump on an E4 brain HDL, could it make it at least less dysfunctional than it is if it only was carrying E4? So I'm going to punt back to Kellyann to give you a little more brain discussion, but at least we've sort of stuck our toes in the end of the lipid pool in the brain so far. We got to get into the deep end in a little while, but that's enough for me from now.
Going back to your question, Simon, and how this relates to ApoE4 and accumulation of things like tau or amyloid, it is really important to understand what ApoE4 is doing in the brain. And what I was going to say before I butchered everything and needed my phone a friend Tom is that it really blows my mind how many neurologists don't have any sort of understanding of the lipoprotein system in the brain. And you really can't think about preventing or treating neurodegenerative diseases without a basic understanding of how cholesterol works in the brain. After all, after the adipose tissue, the brain contains the highest level of cholesterol in the body. So without a basic understanding, we can't really start to talk about how do we address or treat these diseases. So I do want to give you a basic idea of what ApoE4 is doing and how that could potentially lead to things like Alzheimer's disease and Lewy body dementia. So as Tom alluded to, there are lots of different types of brain cells, but there are two main types of brain cells. Neurons are the classic beautiful ones that we think of with the beautiful cell body and this beautiful dendritic arms and looks like a tree. They're the ones that are responsible for sending signals between each other, neurotransmission. And then there are these supporting cells called astrocytes. We never really thought that astrocytes were, the prime importance, but as we evolved in our understanding of the brain, we start understanding just how important astrocytes are. So Tom mentioned that there are these two distinct pools of cholesterol. 80% of it is inert, and it covers the myelin sheath, or is the myelin sheath that covers our neurons. So it ensures insulation, ensures that there's swift delivery of electrical impulses between neurons. Then we have the second pool of cholesterol, which is functionally active, and it's extremely important for brain functions. It's important for neuronal growth, repair, remodeling of neuron cell membranes, synaptogenesis, etc. This pool is primarily synthesized by the astrocytes, to a lesser degree the neurons, but that actually changes with age. So with the developing brain, our neurons are the ones that are generating most of the cholesterol. With age, cholesterol synthesis starts to become downregulated in neurons, and neurons become increasingly dependent on cholesterol produced by the astrocytes. How do neurons get cholesterol from astrocytes? Well, they rely on ApoE containing HDL particles. And as Tom told us, the neurons have LDL receptors, so they can take up these particles. Turns out that ApoE4 containing HDL particles are less efficient at delivering cholesterol to neurons. And this is where problems arise. So we know that in the early days when Alzheimer's disease was being discovered by Alois Alzheimer's, he noted that there were these cholesterol droplets or lipid droplets in the neurons of patients with Alzheimer's disease. And that's because likely these cells aren't able to get rid of excess cholesterol. And what happens when cholesterol and lipids accumulate inside brain cells is that it leads to cytotoxicity and neurodegeneration. So this is one potential mechanism by which ApoE4 can lead to neurodegenerative diseases. And the cool thing that Tom alluded to before was that, well, we do have a lipoprotein that can cross from the periphery into the brain, and that apolipoprotein is called
Apoprotein. It crosses, not a lipoprotein.
Okay, there you go. Tom, this is why Tom has to keep me honest. I'm still faking it. I can spin lipids better than most neurologists, but I still need some schooling from Tom.
You're doing a great job. So that's ApoA1.
That's ApoA1. And the idea behind things like CTEP inhibition or a new drug called obicetrapib is that it causes the liver to produce more ApoA1. And the idea is that this ApoA1 can cross through the blood-brain barrier, because we know ApoA1 can do that, and potentially substitute for dysfunctional ApoE4, so can start to regulate that transport of cholesterol between astrocytes and neurons.
Which prevents excess cholesterol from building up in the neuron.
Yes. A key factor, we believe, to neurodegenerative disease related to ApoE4.
Is this one of, if not the most kind of promising therapeutics for someone with a single copy or a double copy of ApoE4?
It's a novel therapy that obviously has to undergo testing to see if the hypotheses we now have is correct. But since obicetrapib, as Kellyann mentioned, if you're on that drug, a lot of the ApoA1 binds to HDLs, which makes the liver start producing more ApoA1, because all the liver knows is, where the heck did the ApoA1 disappear to? I got to make more. So by producing free ApoA1, some of that has the potential to just cross the blood-brain barrier and maybe rescue dysfunctional E4 HDLs in the brain. That is the hope. And now this obicetrapib, a CTP inhibitor, is being developed because it also, in the peripheral circulation, significantly lowers apolipoprotein B. And every drug that does that through an LDL receptor-related mechanism has prevented atherosclerosis. They've already produced data that they can drastically lower LDL cholesterol and ApoB and FH. I believe the FDA usually gives drugs as long as they have safety data. If you can lower LDL cholesterol and ApoB by upregulating LDL receptors, similar to the statins, ezetimibe, PCSK9, you can come on the market before you have outcome data, as long as you show us that you are doing phase 3 outcome trials, and they certainly are, New Amsterdam Pharma. But if it does come on the market, approved to treat hyperlipidemia in FH patients, every other guy or ma'am who's a prescriber can go off label. And will we start to use this in our patients who, where Kellyann discovers them early in life that may be on the road to dementia? I think many of us will start going down that route off label. It will be long time before, and whether New Amsterdam even has the finances to do a gigantic randomized blinded trial enrolling people with AD risk factors as opposed to none and give them this drug, because it takes AD a long time. I guess they'll look at some of the biomarkers of AD and maybe some type of cognitive testing that have been done with the PCSK9 inhibitors, and we will get signs or that, wow, this is going to work or so. But that's the hope with an ApoA1 raising drug, that it can rescue dysfunctional HDLs in the brain. And right now, that is the one lipid drug coming down the pike that has that potential.
Tom, I know in previous discussions you've spoken reasonably strongly about high HDL cholesterol in the periphery not being inherently beneficial or protective against atherosclerosis. And you've spoken about failed drug trials and Mendelian randomization studies that have kind of helped elucidate that post some observational research earlier that had suggested there was this association between high HDL cholesterol and lower risk of cardiovascular disease. How do you feel about, given what you've just stated here about ApoA1, and that's a protein that's found on high density lipoproteins in the periphery that can cross the blood-brain barrier just as a protein by itself, not as a lipoprotein. Is there any research to suggest that high HDL cholesterol in the periphery is directly protective against dementia through ApoA1?
Let me answer that quickly, and I know Kellyann wants to chime in on this too. This HDL cholesterol, which everybody has been making bets on forever, hey, high HDL cholesterol, you're immortal. Low HDL cholesterol, if nothing else, you're going to have a heart attack and not live very long. And if we look at population evaluations of thousands and thousands of people, that's sort of a generality that is true. But when you start applying HDL cholesterol metrics to individual people, you're going to make a fool of yourself, because not every person follows the rules that a population may follow or so. So we now know there are people with low HDL cholesterol who do not wind up getting heart attacks. And vice versa, there are people with a high HDL cholesterol who previously were told they're immortal. And an aside of that is women tend to have higher HDL cholesterols than men. So women have been told for decades, we don't care what your ApoB or HDL cholesterol is. Your quote unquote good cholesterol is saving you. So this is utter nonsense, and we have to get away from that. So if you look at the type of studies, and they're all either post hoc or observational, there are segments of people with high HDL cholesterol who wind up with various adversities, including ischemic coronary artery disease. I've seen one trial linking it to a type of breast cancer, and there is a trial linking high HDL cholesterol to a higher incidence of dementia or so. If you read those articles, that association, which is certainly not randomized, blinded type of observation, the authors can give you no explanation as to what might be going on, except, hey, this is what we saw. And I think the golden rule to take from that, if you have a high HDL cholesterol and you've gone to some practitioner and he's granted you immortality because of your high HDL-C, or that you're protected against everything, that's nonsense. Don't believe it. Now, I don't know how to tell any man or woman who might have high HDL cholesterol, you're going to have dementia, unless I start running the battery of tests that Kellyann might run on somebody or so. In the lipid world, I can start looking at ApoB or the more causal factors to try and, you're the person with high HDL cholesterol who is going to have a heart attack because your ApoB is through the roof. So who cares what your HDL cholesterol is? HDL cholesterol metrics have nothing to do with the functionality of the HDL particle. The one thing I don't want people to think, but high ApoA1 means you have high HDL cholesterol. Absolutely not. HDL particles can have from 1 to 5 copies of ApoA1. So you could have big HDLs carrying very few copies of ApoA1. The HDL cholesterol is high, but the ApoA1 is not. Likewise, you could have a lot of small HDLs, but maybe they're carrying extra copies of ApoA1, but they're not carrying very much cholesterol. So ApoA1 is high, but HDL cholesterol is low. So understand, I got a nice graphic, ApoA1, and then there's an equal sign with a dash through it, does not equal HDL cholesterol. Another equal sign with a dash through it does not equal HDL functionality. So be careful thinking these markers are related to one another, ApoA1, HDL cholesterol, or HDL particle count. They're not.
This is why we need more conversations like this, by the way. It's because the people who are writing a lot of these articles are neurologists like me with no actual background in this topic. And this is really how this union became, I would send Tom articles and he'd be like, they did not have anyone with any knowledge of the lipoprotein system reading this. We just need more cross-cutting specialties, and interests in neurology and cardiology need to be more united to really make a lot more sense of these associations that we find.
I don't want to insult every neurologist. No, true, they're extremely deficient. But if you round up the average primary care physician or even the average cardiologist and you start asking them about brain lipids, zero knowledge of it for the most part. So it's fortuitous that I bumped into Richard a long time ago. And we started getting an interest in lipids, and then, boy, my path got so much brighter today. Kellyann and I became colleagues because we did a lot of chatting like this back and forth, sharing articles, reading it. And even when I took the deep dive into the brain, thanks to Kellyann, I just was reading so many articles, and the peer review of even people writing about the brain lipoproteins who should know better, lipidologists, there's so much errors in all these articles. So you just, it's tough to figure this out. Kellyann and I are slowly working on a better compendium to put this all together, and it will come to fruition. And it's well needed out there, that's for sure. But it is complex. And as Kellyann knows, it keeps changing even now. So once we come up with a set of ideas, along comes a new article. Ooh, we have to rethink that aspect of it. But there's a lot to learn, and very few people understand this world right now.
Yes, I certainly agree that this type of collaboration is almost never a bad idea. My question earlier, Tom, where I was asking about HDL cholesterol, so I was wrongly presuming that high HDL cholesterol meant high ApoA1. So now I understand that those are different. And my thinking was, I was thinking of someone with a copy of ApoE4 or 2 copies, and whether doing things with their lifestyle to raise HDL cholesterol could be a benefit by increasing ApoA1, getting more of those across the blood-brain barrier. I now understand that that's not going to be a good marker to tell you how much ApoA1 is getting across the blood-brain barrier. Can you measure ApoA1 directly?
Yeah, so it's an immunoassay, and until now, there's been no use to do it because the confusion where there's multiple copies of ApoA1 per HDL particle. In the old days, it was used as an HDL particle biomarker, but it's a guesstimate at best. Now, once NMRs came along, if you want them for whatever reason, they can give you very accurate HDL particle counts. But in the periphery, we really have not been able to tie that into anything. And I don't know where we're going with it in the future or so. But you just have to keep these biomarkers separate. I don't see a big future for measuring ApoA1. Even if obicetrapib and proves it's going to be good for doing it, maybe they'll have some data tying that into ApoA1 concentrations, but we're a long way from, shouldn't even speculate about that now. It's a transferable apoprotein. It can jump around from this thing to that thing. And I love confusing things. I told you what a small apoprotein ApoA1 is compared to the big monster ApoB and even the truncated ApoB48 that's in chylomicrons. There's a couple of, ApoE is not that much bigger, but it cannot cross the blood-brain barrier. But there are a couple of other apoproteins that are rather small, a little bit bigger than ApoA1, that almost certainly can cross, and it's a couple of members of the ApoC family, which we know do exist in the brain. I don't think we have much of an idea what the heck ApoC 3 or 1 are doing in the brain. In the periphery, C3 can be a bad guy, but so there are other apoproteins that can cross the blood-brain barrier, but they're not going to be part of our discussion for now because unless Kellyann knows something, I think we'd be sheer over-speculating what they do in the brain.
Kellyann, I think I know the answer to this given what we spoke about earlier with regards to the kind of new biomarker tests that you were talking about that could predict risk. How do you feel about someone going out and doing a genetic test to see if they have a copy of ApoE4 or 2 copies?
It's really, again, based on the individual. I personally think that there's so much value in getting knowledge, but again, you have to really understand what your appetite is. If you feel like this isn't going to change the way that you act and is only going to cause you unnecessary stress and worry, then it's not the right thing for you. But I think for most people, the knowledge is so empowering. And I really, really emphasize that ApoE4 does not mean you are going to get Alzheimer's disease, dementia, Lewy body. It is just a risk factor. And it's a risk factor that we actually know a lot about, and we can potentially do things to get someone off the path to neurodegeneration if we understand that you have this risk factor. So to me, it's knowledge that can help change how you act. I think it provides value.
The problem with that knowledge is if you do get your ApoE genotype, you are obviously going to have to speak to a medical professional about it. And again, I told you the PCPs and cards know little about brain lipids. Most of them can't give you much of a coherent discussion on what ApoE4 heterozygosity or homozygosity might mean. And they could scare the bejesus out of them. They could mistakenly perhaps say, ignore it without looking at other things. So the problem is, there's one preventive neurologist here and we're looking at her. So we need, once a person tests themselves, they have to try and find competent care to get answers.
Yeah, that's a really important point. I like to think about all these people at risk, and I'm out here telling people like, yes, knowledge is power and it's so wonderful. But, if you suddenly become aware of what your risk is, where can you turn for help? Right now, it's really hard. And a lot of this is self-discovery and self-education. And that's why there are people like Tom and I out there trying to help spread knowledge so that you could understand this the best that you can, because it is difficult in terms of getting the right type of medical care right now.
And even in my world, knowing the ApoE genotype can provide substantial information about cardiovascular risk also. But again, I think if you ask the average PCP and even card, how do you tie in ApoE genotypes to lipid disorders, you'd get a lot of blank looks back. So it's a problem.
Breaking away from the episode for a moment here, as mentioned earlier, we had planned for this episode to concentrate on the 14 modifiable risk factors identified by the 2024 Lancet report on dementia prevention, intervention, and care. The Lancet report suggests that if these 14 modifiable risk factors are eliminated, or in other words, optimized at specific stages of life, almost 50% of all dementia cases could be prevented. The 14 modifiable risk factors are as follows: low quality education, especially in early life, hearing loss, high LDL cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excessive alcohol consumption, social isolation, air pollution, and visual loss. Importantly, these are not all equal in terms of the risk that they pose, with some of these like LDL cholesterol, hearing loss, poor quality education, and social isolation being more significant in the effect that they have on dementia risk. Today, we are zooming in on cholesterol, and more specifically, high LDL cholesterol. And then we'll double back in a future episode with Dr. Kellyann Niotis to discuss all 14 of these modifiable risk factors. Okay, back to the episode to learn more about ApoE4. Friends, if you're looking to sell products online, Shopify is where you need to be. Sure, you can list your product on various marketplaces today, but there's a big advantage to having your own e-commerce store. With Shopify, you're in control of your customers' data and can build direct relationships with your audience, which is key for boosting their lifetime value and scaling your business. Shopify makes setting up an online store an absolute breeze. It's designed not just for web developers, but for regular folks like you and me, making it easy to bring our vision to life with just a few clicks. Check out 38terra.com, an example of a site that Dr. Will Bolsowitz and I built using Shopify. Start by selecting one of 200 plus customizable Shopify themes, and then use the Shopify App Store to improve your marketing, store design, order fulfillment, and more. To get your product out there, boost your conversion rate, and grow your business, start today, right now, by signing up for a $1 per month trial at shopify.com/proof. That's shopify.com/proof. If someone does their genetic testing and they have a copy of ApoE4 or 2 copies, does that affect which of these risk factors you are sort of maybe going more aggressive on or spending more time on? Or is the prevention kind of plan going to be pretty similar to someone without a copy of ApoE4 or 2 copies?
I believe in precision medicine. It really does change the way that we treat you. Of course, how ApoE4 relates to these modifiable risk factors is the elevated LDL-C risk factor that we're talking about, and Tom just mentioned. And he can talk more about how ApoE4 influences peripheral LDL concentrations. But even when we think about treating LDL-C in someone who has an ApoE4, well, that really changes. So for example, ApoE4s tend to be hyperabsorbers of cholesterol. They absorb more cholesterol from their intestines. Turns out that we actually have a great medication that can block cholesterol absorption in the gut called ezetimibe. That also has the benefit of not crossing the blood-brain barrier and not doing anything to screw up brain cholesterol synthesis. As we've been honing in on, the brain must synthesize all its own cholesterol. It can't take up cholesterol from the periphery. So while there haven't been any studies that have said that statin therapy is harmful, and I don't think that it's harmful at all, I do think we need to individualize or think about how we're treating LDL-C in relation to someone's risk factors, in relation to other biomarkers, which Tom can talk a little bit more about, and specifically in relation to ApoE4, because we understand that their brain cholesterol synthesis or homeostasis is not normal.
Just sometimes you think of things that you didn't think of originally. And you mentioned this cohort where high HDL cholesterol was associated with dementia. And we just tied in LDL cholesterol, which is really tying in peripheral ApoB to a risk factor associated with dementia. And Kellyann rightly knows that in general, people who have E4 alleles tend to be hyperabsorbers of cholesterol. But very interesting, untreated hyperabsorbers of cholesterol tend to have higher HDL cholesterol also. So I would wish that we could go back to that cohort of high HDL cholesterol and dementia and do a sterile absorption test on them. Now, they had very high HDL cholesterol. Typically, hyperabsorption doesn't put you into that range, but you know me, I'm always tying things into lipids. So,
Tom, maybe we should talk a little bit about the idea of desmosterol and what we've noticed in the patients that we've cared for.
We could. I perhaps would rather save that part of the talk, and whether that's today or we devote another episode to it, is really cholesterol homeostasis in the brain. Because starting in utero, what happens during childhood and what happens in adulthood. And we don't want to do all that now, but just to briefly address what Kellyan's talking about, the only way brain has cholesterol is it synthesizes it de novo. So, and it hangs on to it for dear life. The half-life of cholesterol in the brain is 5 years as opposed to a couple of days in the periphery. So that tells you the brain really looks at cholesterol molecules like a bank looks at gold bars. It wants them and it never wants to get rid of them. So cholesterol is synthesized in adults in the astrocytes primarily. It's put in these lipoproteins that travel through the matrosome and deliver it to the neuron. So you never would want to oversuppress cholesterol synthesis in the brain. Now, she started off by saying, when you do autopsy studies on these AT, you got a lot of abnormal lipids and sterols floating around the brain. So you don't want to have too much cholesterol in the brain, too. And when we get into that homeostasis discussion, there is a mechanism for neurons to get rid of cholesterol and send it back to the plasma. Again, we're not going to go there. But so a little bit of cholesterol suppression in somebody with risk factors for Alzheimer's disease, a little bit of suppression of brain cholesterol might not be a bad idea. And that's why if you look at all the statin trials, and there have been so many, none have been randomized, blinded to prove what statins do to cognition or not, but there's plenty of post-hoc data and observational data that statins do not increase or worsen dementia in the entire population if we gave everybody statins. And there's a few studies that suggest they might even do good as far as preventing. But everybody who's ever written a statin knows there's a very small percentage of people who rapidly come back and saying, Doc, this drug doesn't agree with me. My brain's not working right. I'm not adding correctly. I'm not thinking. I'm not sleeping, whatever. And that has been given the name of brain fog. It's in the package insert. So the FDA has recognized this is a small but potential side effect of statins. So what we now hypothesize, and I want to emphasize everything I'm about to say is hypothetical, but it sort of makes sense for now, that might that be a person where for whatever reason the statin has over-suppressed cholesterol synthesis. Now the astrocyte can't make cholesterol. All of a sudden the neuron's a little cholesterol deficient. You're going to get neuronal dysfunction. And is that possible? If it is, God, is there any way to get a handle on brain cholesterol synthesis homeostasis? And there actually is. So, Simon, we've talked about cholesterol synthesis. If people go back and listen to our earlier podcasts, they know there are two pathways that cells have of synthesizing cholesterol. Evolution gave us dual pathways for a variety of reasons. One being just it's good to have redundancy for a critical molecule like cholesterol. So the peripheral cells go through a pathway that ends up with lithosterol becoming cholesterol. Whereas brain cells and interestingly steroidogenic cells, and just like the brain, steroidogenic tissues need to produce a lot of cholesterol, more so than peripheral cells, which need very little cholesterol. They use the desmosterol pathway, the block pathway as it's called. So if astrocytes are primarily synthesizing cholesterol through the block pathway, the penultimate sterol that becomes cholesterol is desmosterol. Kelly just mentioned that sterol. So could we measure desmosterol in the periphery? Because we don't want to wind up doing spinal taps on our patients and checking desmosterol. But lucky for us, some investigators have done that. And they found out not only are there X number of people who have low desmosterol in the cerebrospinal fluid, those people are prone to developing cognitive impairment or even Alzheimer's disease. They then went on, thank God, to say, let's take cerebrospinal fluid desmosterol and correlate it with peripheral plasma desmosterol levels. And there's a nice high correlation. And the conclusion of that study was, hey, we can use serum desmosterol as a biomarker of risk for Alzheimer's disease. So now let's go back to I'm throwing somebody on a statin. Most people are not going to come back and say I'm having brain fog. If they did, we'd wind up stopping the statin anyway, so they get excluded. They're not having long-term. They wouldn't keep taking the statin long-term if they knew it was screwing up their mentality. But what if I could identify some people where desmosterol was low, suggesting statin oversuppression of brain cholesterol synthesis, but they're sort of asymptomatic. They're not complaining of brain fog. If we let that go for years, could that very tiny group of people be sort of being sent down the cognitive impairment pathway due to statin monotherapy? So what we tend to do nowadays for those of us who monitor desmosterol, and I know my old buddy Richard and I know Kellyann and any patient sees it, they take a close look at desmosterol. And if it's being oversuppressed, Fortunately, we have many other ways. Why are you writing a statin to lower ApoB? We have numerous other modalities that can do that nowadays, even without a statin, or you could use a far lesser dose of a statin, perhaps. So I believe desmosterol right now might be very usable as a way of getting handle on brain cholesterol synthesis. I think if day one I monitored desmosterol was very low, I don't think a statin is an appropriate drug for you to lower ApoB. I'll go to everything else that's in my armamentarium. So that brings the desmosterol biomarker into a little bit more of a focus. And way more on this later when I can really give you my diatribe on total brain cholesterol homeostasis.
This is just emphasizing the importance of really being precise in what types of therapies you recommend people and taking into account things like genetic risk factors and other biomarkers when you pick the right therapies for people.
All of our other lipid modulating drugs, which are ezetimibe, bempedoic acid, PCSK9 inhibitors, do not inhibit cholesterol synthesis in the brain. So the PCSK9 can't even enter the brain. The bempedoic acid works only in the liver, and ezetimibe works only in the gut. So we don't have those desmosterol worries with the other lipid modulating drugs.
Tom, is it true that some statins are hydrophobic, some are hydrophilic, and therefore not all of them are able to cross the blood-brain barrier and have that effect on cholesterol production within astrocytes?
It's an old-time hypothesis that dates back to the very early days when we had, for many years, the only two statins on the market were two incredibly lipophilic statins, simvastatin and Mevacor, which was lovastatin, and we had one hydrophilic statin, pravastatin. And pharma marketing used to run around saying, hey, there's no brain fog with the hydrophilic pravastatin, and there's more brain fog with the lipophilic Mevacor and Zocor or simvastatin. More pharma marketing and wishful thinking. As it turns out, many years later, once you get any statin in a steady state, they all cross the blood-brain barrier. So it's irrelevant whether you're using a hydrophilic or a hydrophobic or a lipophilic statin. But that old sort of wives' tale persists big time in the real world. I get that question frequently asked of me. But no, so you pick whatever. You should be picking a statin for its ability to lower ApoB and perhaps for what drug-drug interactions it might have in a polypharmacy world. No other decision should come into which statin you're picking.
Side effect profile.
Yeah, and most of the side effect profile is related to drug-drug inter. They all can cause muscle aches. You can't separate them that way. They all have a slight propensity to cause AST, ALT. There's not one statin that's better than the other. All but one can slightly increase insulin resistance and may slightly predispose to diabetes, pitavastatin being the only one that does not seem to have that property. That's a branded statin that has almost no real-world use. But if you were worried about that, that would be your statin of choice. So in general, you pick we tend to go with rosuvastatin. It is hydrophilic, but I can show you studies where rosuva caused actually a little bit more cognitive impairment than the lipophilic atorvastatin. Again, it's observational data, so who knows? But rosuva happens to be at the lowest dose, the most potent ApoB-lowering statin. So if I'm going to use a statin, I'm in the category of, hey, I want baby statins, low-dose statins, and if I need something else, I'll add to it, rather than throw you on the high-dose statin, just asking for trouble.
Howdy, friends. Me here again for another quick breakout to summarize the key points from this part of the conversation on brain cholesterol levels, statins, and cognitive decline. There's this idea out there that lowering blood cholesterol levels increases risk of dementia because the brain needs cholesterol. The first point that I want to reiterate here is that if you use lifestyle changes, predominantly diet, to lower your LDL cholesterol, this has no effect on brain cholesterol levels. Cholesterol in your brain is produced locally, mostly by astrocytes, which is unaffected by your diet or blood cholesterol levels. It's a myth and a gross misunderstanding of basic physiology that eating foods to increase cholesterol means more cholesterol in the brain. That's simply not how it works. Secondly, when it comes to medications, randomized controlled trials and observational research suggest that lowering LDL cholesterol with lipid-lowering drugs such as statins is beneficial, or at very least neutral when it comes to preventing dementia. Presumably because lowering LDL cholesterol helps prevent atherosclerosis in arteries supplying the brain with blood, meaning the brain is exposed to more nutrients and less inflammation. That said, despite there being no strong evidence that statins increase risk of dementia, there is some research suggesting that people with existing mild cognitive impairment and Alzheimer's dementia have lower levels of desmosterol, a precursor to cholesterol, in the brain. Because of the nature of these studies, we don't know if low desmosterol causes dementia or if low desmosterol is a downstream consequence of dementia. That said, it is known that certain statins, particularly at high doses, can cross the blood-brain barrier and reduce desmosterol levels in the brain. If you are taking a statin and are worried about this, you can order a desmosterol test, again from a company like Empower DX. If your desmosterol levels are low, you can then chat with your physician or cardiologist about lowering the dose of the statin you're taking or changing to a different type of lipid-lowering medication. Personally, if I was taking a statin, even though we don't yet fully understand the nature of this relationship, I would play it safe and do this until we know more. Okay, back to the conversation to learn more about LDL cholesterol as a risk factor for dementia. While we're on cholesterol here, Kellyann, which was one of two new risk factors added to this latest report, along with, I think it was vision loss or hearing loss, one of those two. So I think people listening that are kind of following along, and I appreciate this is quite detailed. It's been covered in some previous episodes, but hopefully we're covering enough detail to help people kind of grab a hold of it. They might be thinking, okay, I understand that the lipoproteins in the periphery are distinct and separate from lipoproteins in the brain. But then you're saying high LDL cholesterol is a risk factor for dementia. If low density lipoproteins or ApoB containing lipoproteins like Tom and I have discussed previously, which is probably a little more specific, are not crossing the blood-brain barrier and depositing cholesterol in brain circuitry within neurons, what's the proposed mechanism by which elevated LDL cholesterol in the periphery is having an effect on dementia?
Yeah, so just because it's not crossing the blood-brain barrier doesn't mean it's not accumulating in the blood vessels that feed the brain, the small blood vessels, the large intracranial vessels, the carotids. Of course, the brain needs two primary things to be healthy. We're going to talk about the activation component, but it also needs fuel. Fuel comes in the form of blood flow, oxygen, vitamins, nutrition. If you're cutting off glucose, all those things. If you're cutting off blood flow delivery to the brain because there's atherosclerotic disease, that's obviously a problem in itself. But also think about the downstream inflammation that happens with atherosclerotic disease in the periphery. That inflammation, while LDL isn't crossing the blood-brain barrier, we do know that that inflammation can cross the blood-brain barrier. We do know that there's this relationship between high sensitivity CRP, atherosclerotic disease, but also brain atrophy and dementia. Tom, do you have any other mechanisms there?
No, I think you're exactly right. High LDL cholesterol is usually associated with a bunch of other metabolic abnormalities. And the most common cause of lipid ApoB disturbances nowadays is insulin resistance. So is that part of the explanation why, hey, high LDL-C is associated with it? To get real ugly, Kellyann and I discovered within the last year, ApoB, we don't all produce the exact same type of ApoB. There are variants of ApoB. And some researchers have identified a couple of ApoB variants produced in the liver that if that's the type of ApoB you got in wrapping your particles, that seems to be compared to regular ApoB that is not of these variants, is significantly associated with Alzheimer's disease. Again, I don't think we know why. Is that a type of ApoB that just is formed for atherosclerosis in the cranial arteries? But there's always more to any study. So there are different variants of ApoB. They're rare. This is not the run-of-the-mill ApoB that most people have, but there's more to the story, as always.
Okay, folks, just us again for another quick breakout. There are a few points here that I really want to stick. Number one, cholesterol levels in the brain are separate to the periphery. Although LDL cholesterol is a risk factor for dementia, it's not that cholesterol in your blood that you test on a blood test in these low-density lipoproteins crosses into the brain. That does not happen. Number two, high LDL cholesterol is thought to primarily increase risk of dementia by causing atherosclerosis in arteries that supply the brain with blood and therefore key nutrients. This atherosclerosis in arteries supplying the brain with blood is also thought to increase inflammatory proteins that can cross the blood-brain barrier and damage cells in the brain. Number three, getting your LDL cholesterol, or more specifically ApoB, to goal as early in life as possible is one of the most important things that you can do to prevent dementia. The 2024 Lancet report suggests that one can reduce their risk of dementia by 7% by addressing this single risk factor. This can be achieved with lifestyle, which I outlined in my recent video on dietary fats, and or using lipid-lowering medications, depending on the person. Okay, back to the episode to clarify a statement made in the 2024 Lancet report on preventing dementia that contradicts this idea that low-density lipoproteins, or LDLs, do not cross the blood-brain barrier. There's a paragraph in this report that confuses me, and I suspect it will confuse others, given what we've spoken about here about the blood-brain barrier and cholesterol not crossing it. And it says, excess brain cholesterol is associated with increased stroke risk and deposition of brain amyloid beta and tau, suggesting a potential mechanism for the link between LDL cholesterol and dementia. Is that confusing to you too?
Yeah, and there's no peer review on that article. Because if I'm doing peer review, how the hell did you measure brain cholesterol would be my first question. And if they can't report that, then how do you know there's too much cholesterol in the brain? So I think they confuse brain cholesterol with LDL cholesterol, has to be my guess.
Yeah, this is the same school of thought I came from before I met Tom, thinking that, LDL cholesterol goes into the brain, but it clearly doesn't. So I think it's a poorly worded sentence.
The kind of take-home point here when we're considering LDL cholesterol is that even though it's in the periphery and low-density lipoproteins are not crossing the blood-brain barrier, it is advantageous from a dementia prevention point of view to get LDL cholesterol down to a certain goal, and maybe we can discuss what that looks like, to prevent certain pathology in the periphery that can affect brain function, brain health.
Yeah, and this was one of the most modifiable risk factors in the report. They attributed 7% of dementia cases to elevated LDL-C cholesterol. And I think that could be variable dependent on the person. So maybe in an ApoE4 carrier where having high LDL-C, having high ApoB is a primary driver for their disease process, that could be a huge, huge portion of their dementia prevention risk strategy.
And my two favorite preventive neurologists are very aggressive in making sure ApoB is controlled in their patients because it's one part of this scenario there.
How much does one copy of E4 increase risk of dementia, and how much does 2 copies of E4 increase risk? And how prevalent is that?
Yeah, I get asked this question all the time, and I can give you the textbook answer and tell you why I hate rattling off numbers to patients. But the textbook answer is that carrying 2 copies of the ApoE4 gene increases your risk of Alzheimer's disease and Lewy body dementia on the order of 12-fold, 18-fold, up to 20-fold. We can discuss what that means. And having one copy of the ApoE4 gene increases risk of dementia somewhere between 2 and 4-fold. I really, really, really hate rattling off these numbers because it's really important to understand that there's this complex interaction between ApoE and biological sex, aging, ethnicity, lifestyle factors like your physical activity, diet, and environment. And then, of course, other genes like Klotho, genes upstream and downstream ApoE4 that really help us or can alter the expression of ApoE4. So it's not enough to just take ApoE4 and give someone your risk is 4 times higher. It really could be no times higher. If they don't have a family history and people have been living into their 90s, well, that person's probably not 4 times higher with one copy of ApoE4. So population-based data doesn't, of course, apply to the individual at hand.
I don't hear much talk about ApoE2. I think Tom mentioned before E3 is the wild type. That's the most common. What do we know about E2? If someone was to test and they get E2 or E2, E3, what does that mean?
Yeah. So first and foremost, it's important to understand that no matter what your ApoE genotype is, you can still get dementia. So when we say that people with an ApoE2 allele are at a lower risk of dementia, that is true, but they still can and do get dementia. When they do get it, it happens to be at a later age, late 70s, early 80s, compared to somebody who carries an ApoE4 allele, which might be in the late 70s, compared to someone who carries 2 copies of the E4, which means dementia might happen sometimes in the late 60s. I think ApoE2 is so important in so many ways. And we like to tell people, like, you hit the genetic lottery when you got ApoE2 because you're at a lower risk for dementia and it's considered this longevity gene. But, it does increase your risk for age-related macular degeneration. And we now know that vision loss is a modifiable risk factor for dementia. So it's something to keep in mind. Like, you might be at a lower risk of Alzheimer's related dementia, but you are at a higher risk of other things like age-related macular degeneration. And we didn't really talk about this when we were talking about the umbrella term of dementia, but there's this other entity called cerebral amyloid angiopathy. And this is a form of dementia that is related to Alzheimer's disease. But instead of amyloid accumulating in the brain tissue, amyloid starts accumulating in the blood vessels. And it makes the blood vessels very friable and prone to bleeding. So people who have cerebral amyloid angiopathy often have hemorrhagic or bleeding type strokes, which can be catastrophic. They can also have cognitive decline. There are some studies out there that have been showing that ApoE2 carriers actually might be at a higher risk of cerebral amyloid angiopathy. This is something that's an area of active investigation and more studies need to look at it. But I think it's very important because if you do find someone with an ApoE2 allele, you should really make sure they don't have any small evidence of microbleeding on their brain MRI. So check a brain MRI. These are people you should just be careful about in terms of, do you put them on anticoagulation? If they're taking aspirin, are they at higher risk if they hit their head? There are just lots of implications that come along. And this is why I think understanding your ApoE genotype can be really, really helpful.
I know we might be skipping ahead here, but it seems relevant because often when the ApoE gene is discussed, this topic of omega-3 supplementation comes up. And sometimes people have thoughts around dose, choice of omega-3 for different people depending on their gene results and if they're an ApoE4 carrier or not. Do you have any kind of strong thoughts about this, or what does the research show? Should we be personalizing our DHA EPA supplementation protocol based on our ApoE gene results?
Yeah, we should double click on this topic of omega-3 fatty acids, but let's circle back to another property of ApoE4. So way back in early evolution, ApoE4 was actually thought to be beneficial. It was beneficial because people who carried this gene were at a lower risk of infections. That's because it promotes inflammation and helps us fight off infections. Well, as we've eliminated infectious disease from our potential killers, and now we're left with more chronic diseases like Alzheimer's disease, that tendency to produce inflammation and neuroinflammation can be problematic and can lead to neurodegeneration. Turns out that we have something that is low risk and potentially anti-inflammatory, and that's omega-3 fatty acids. And this is a really complicated topic, and Tom can school me on it more, but what is the evidence behind ApoE4 carriers needing higher amounts of omega-3 fatty acids? So there's a specific type of omega-3 fatty acid called DHA. EPA is the one that we think of when we think of cardiac disease and heart health. DHA is the one that we think about for brain health. There have been studies by investigators, specifically Dr. Yassine is one of these major investigators looking at DHA supplementation in ApoE4 carriers. And at baseline, what we understand is that CSF concentrations or spinal fluid concentrations of DHA in ApoE4 carriers are lower. And that value is worse the further along someone goes in the neurodegenerative process. So the more neuropathology you have, the lower DHA you have in your cerebral spinal fluid. There have also been studies showing that in order to get to the same CSF or spinal fluid level of DHA that an ApoE3 carrier has, you have to dose someone with 2 grams of DHA daily. So an ApoE4 carrier might need up to 2 grams of DHA daily to get enough DHA delivered to the brain due to this propensity for neuroinflammation and this dysfunction of the blood-brain barrier in ApoE4 carriers. We don't know right now if supplementing DHA has any major impact on Alzheimer's disease risk because there haven't been any prospective studies on that. That's what the Prevent-E4 study that Dr. Yassine is doing will show us. Does supplementing high doses of DHA have any impact on imaging biomarkers of Alzheimer's disease? And those results are expected in 2025. So more to note on that later, but just looking at epidemiologic studies and population-based studies, we do know that ApoE4 carriers who eat at least 1 serving of a fatty fish or supplement with omega-3s have a lower amount of AD-related pathology post-mortem. So omega-3 fatty acids likely do something to AD-related pathology.
Is that the only kind of, I guess, specific difference in nutrient requirements that has been observed, or are ApoE4 carriers? Is there other differences for other nutrients like B vitamins, for example?
Well, because of what we alluded to before when we were talking about how ApoE4 carriers tend to absorb more cholesterol from their gut, Tom might be able to comment more on this, but they tend to have more beneficial effects on their LDL-C and LDL-P if they consume extra virgin olive oil or monounsaturated fats. And I have witnessed in ApoE4 carriers that consume a high saturated fat diet that really does seem to impact their LDL-C, ApoB, LDL particle count much more than ApoE3 carriers. So it does change the biology of the food that we eat.
Tom, do you have any thoughts on that, being an ApoE4 carrier, and whether modifying the type of fat you're eating has a greater difference, I guess, on LDL cholesterol?
Well, the easiest thing to do, of course, I want everybody to have their ApoE genotype or something, but I will also want everybody to have their omega-3 index very earlier in the game too. And most people, regardless of their ApoE genotype in the United States, are going to have low omega-3 indices. So all of us need to be supplementing omega-3 fatty acids. And as Kellyann mentioned, there's two of them, DHA and EPA. And I'm talking in general now because this discussion gets a little more elaborate if you're talking what types do you want to give to high-risk cardiacs or so. So we're not talking about them right now. So, if you're relying on what you eat to raise your omega-3, and Kellyann mentioned, hey, fish eaters seem to have a little less of a problem than non-fish eaters. The omega-3 fatty acids are carried in the phospholipids in the cells of, the plankton that the fish ate, and we're eating the fish. And so we're eating phospholipids. They have to be hydrolyzed in the gut by intestinal pancreatic lipases, and then the free fatty acid gets absorbed, or the phospholipid with only one fatty acid called the lysophospholipid can be absorbed. And then they go right up to they enter the enterocyte. Now, the fatty acid absorption really has nothing to do with the sterol absorption. Very different receptors. It's fatty acid transport proteins that are pulling in these various fatty acids, where it's the Niemann-Pick that's pulling in the sterols. Niemann-Pick's not pulling in fatty acids. But these omega-3s get in, as do other fatty acids, and the enterocyte just reassembles free fatty acids, free EPA or DHA that just got absorbed, back into phospholipids, which go on the surface of your chylomicrons, or they can be effluxed a little bit to HDL particles that are lipidating at the intestine. When the big chylomicron goes up into the muscular bed and gets exposed to lipoprotein lipase, all the phospholipids carrying EPA or DHA break off and bind to phospholipid transfer protein. Typically, they're brought over to HDLs because HDLs need a lot of phospholipids. But these phospholipids can also be delivered up to the blood-brain barrier, and especially lysophospholipids, I believe, can transverse that blood-brain barrier. So if you have a lysophospholipid carrying DHA or even EPA, that's how it's going to get into the brain. But look, she can quote you chapter and verse on the DHA being the more important, perhaps, long-chain fatty acid up in the brain. But the absorption's a little bit complicated. And if you have E4, is there a difference in intestinal absorption of the fatty acid? Not that I'm aware of, but I don't know that data that well. I think you just got to check your baseline omega-3 fatty acids and then drown yourself in the type of omega-3 product that is most, and I think you would know who really needs the higher DHA by doing some of these other biomes. For sure, your E4 genotype would be your simplest test to do. And then after X amount of months, repeat the omega-3 index and see how you've done. The omega-3 index can be broken down into EPA and DHA. I think the data is a little weaker on interpreting that. But so therefore, I think right now we're just really want a very high omega-3 index, maybe 10% or more in somebody prone to dementia. Whereas for cardiovascular purposes, I'm happy if you can boost it up to 8%.
Yeah, I just had Bill Harris back on the show recently. And his suggestion at the moment was to look for something, that is close to a 50-50 split of EPA and DHA. And he seems to also like that 2 grams a day, not as a rule, but a kind of general heuristic starting point for most people to get to an omega-3 index of 8 to 12%, which seems to line up with what you just mentioned before, Kellyann.
And most of the commercial products do not have that sort of split with EPA and DHA. They're usually heavier in EPA.
Right. You just have to be careful about what supplement you are using. So people who are super high risk can look for supplements that have a higher percentage of DHA to EPA. I'm not endorsing any specific brands, but there are ones out there that do have a higher amount of DHA.
Just quickly, because we didn't quite close the loop on LDL cholesterol, are the targets for LDL cholesterol or ApoB for preventing dementia the same as those targets that we've previously discussed, Tom, depending if someone's kind of low risk versus high risk?
Well, I think if we believe what we've discussed today, your main reason to lower LDL cholesterol or ApoB is to prevent atherosclerotic disease in every arterial bed in the body, including extracranial, carotid, and cerebral arteries, as well as coronary arteries, but peripheral arteries, your aorta. So, and study after study, it's just not even arguable anymore that you really want to be almost hypo-beta lipoproteinemia because those people don't get any atherosclerosis. And it's pretty much an ApoB below 50. Right now, the guidelines do call for an ApoB below 50, but only in the total nightmares of the world. People have survived strokes or heart attacks. We take the more preventative approach. Hey, if that's good for them, why isn't that also good for you much earlier in life? As long as there's no downside to whatever therapy I'm using to achieve making you hypo-beta lipoproteinemia. And there's pretty much not. And that can be accomplished with obviously some combination of lifestyle that might be appropriate to a given individual. And usually if you want hypo-beta, you're going to have to use an ApoB lowering drug to get those type of levels. So that's our approach to it now. We're very aggressive. I've just seen too much atherosclerosis in my life. Kellyann has seen way too much neurologic disease. And if we can say there's no downside to doing this, why are we not doing it? And again, Simon, I can't reiterate it enough. We've discussed it elsewhere. Because of aggressive lipid modulating therapy, I can make an ApoB 30 or an LDL cholesterol 10. There is zero evidence that that has any effect on cerebral or any other type of neurologic functioning for the reason we just told. Plasma cholesterol is a separate pool of cholesterol apart from brain cholesterol. And the sooner more people would recognize that and get onto it, they would stop all this idiocy that you're destroying your brain by lowering plasma cholesterol concentrations.
The other one that I often laugh at is, eating the 10 eggs a day because your brain contains 20 to 25% of whole body cholesterol.
We've heard that.
let's eat a lot of cholesterol so that it gets up to the brain, which I think we've kind of thoroughly debunked.
And just an aside, and we've discussed this, Simon, I don't think because your brain is not requiring on plasma cholesterol, driving your plasma LDL cholesterol at 240 is not protective for your brain. So just a little bit of warning to our lean mass hyperresponder friends.
Okay, we're approaching 2 hours. I think today we've really focused a lot on the cholesterol production in the brain, the fact that this is distinct and separate from periphery. We spoke about how most of that cholesterol production takes place within astrocytes, and then that cholesterol from astrocytes moves through the matrosome, I think you called it, Tom, in these ApoE lipoproteins, which are similar to the ApoB containing lipoproteins in the periphery, but this is what takes place in the brain to shuttle cholesterol from astrocyte to neurons. That transport system can be affected by the type of ApoE or these proteins that your body is making. It could be ApoE2, ApoE3, or ApoE4, or some combination. You'll have two of these genes. And we spoke about why high LDL cholesterol in the periphery, despite not crossing the blood-brain barrier, is a risk factor, and therefore why you should try to reduce your lifetime exposure to LDL cholesterol, high LDL cholesterol. We spoke a little bit about DHA and whether it's more important for particular people who have a copy or two of ApoE4. We didn't quite get to the whole list of those 14 risk factors, Kellyann. So maybe what we do is the next episode we come back and we dedicate that to the 14 risk factors, and we don't have to go so deep on cholesterol.
But then we have to have a third episode on cholesterol homeostasis, starting in utero and going up to adults, because it's a very important part of the story, which we just sort of stuck our toe in the water on today.
Okay, you can hold me to that, Tom. We'll make sure we do that.
So much content.
Was there anything related to what we spoke about today with regard to cholesterol synthesis in the brain or LDL cholesterol in the periphery that you wanted to clarify or add on before we kind of close this one out?
Well, I have short-term memory loss, so I forgot what we talked about earlier in this podcast. So there's just so much. There's always more to talk about. But I hope if you bring us back, you bring us back as a tag team. And then the next one sounds like it's all neurology, but you don't know how much I love listening to Kellyann. We've spent hours together on various lectures or patient interventions or whatever. And if nothing else, even if I don't say a word, I learn so much from her. And if we do devote a podcast to time, all right, get down and dirty with cholesterol homeostasis, I like her around because she can keep me honest and keep me a little more focused. So we're a tag team on this topic, I think.
Yeah, I think we covered everything. I think this is a great primer for people who want to understand ApoE4, want to understand how cholesterol metabolism impacts dementia risk and other cardiovascular disease risk factors. I think the next time we meet, we can talk all about the sensory activation to the brain and these other modifiable risk factors and kind of give some more actionable everyday advice for people.
Well, thank you both very much for joining me today and being so willing to share your knowledge. I know that this episode and the future ones that we'll record together are going to be really, really helpful and empowering for lots of people that are listening. So thank you for that. Kellyann, where can we send people who would like to learn more about everything that you're doing?
Well, two places. So one, I do a lot of research through a nonprofit foundation called the Institute for Neurodegenerative Diseases in Florida. The website is I like igloo, N like Nancy, D like diameter.org. So visit us there. There's great resources, educational resources, ways to get involved in our research. It's a really, really great place to go. And then, of course, if you're interested in speaking to me more and potentially meeting with me, can visit my website and reach out to me, which is www.drkellyanniotis.com.
Perfect. We'll put that into the show notes. And Tom, are we sending people over to Twitter or X at Dr. Lipid?
They could just Google. People seem to have no trouble finding me. But yes, I'm on Twitter at Dr. Lipid. And for professionals, I'm on LinkedIn. So I'm a pretty easy guy to track down. And I'm generous at answering questions to try and point you in the right direction. Obviously, I don't treat people anymore. I'm not in active practice, but I can often punt you in the right direction to people who are. So, and look, you do a lot of good, Simon, with all the topics you get into, and you never seem to run out of topics that you don't want to get into more. So you can see what the feedback is to this, and I think you definitely need a second one with Kellyann onto the deeper aspects of the neurological aspects. And for some of the geeks who want more brain cholesterol or lipidology, again, you know where to find me.
Yeah, I agree. I agree. And I'm just staying curious and having fun. So thank you again. I really appreciate the time that both of you gave us today. I'll see you soon. There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.